Okay, so we're going to be talking about immunity and HIV/AIDS. This is going to be the last part of your Unit 5A that you'll need for our next exam. So our plan is we're going to talk about two things. We're going to talk about altered immune response as well as HIV and AIDS. So starting with our immune system, so our body recognizes its own cells and foreign cells, and this is what our immune system's job is. A couple definitions you need to know. So an antigen is a substance that stimulates an immune response. Allergy or allergen is a substance that sets up an allergic response and is a type of antigen. Leukocytes are white blood cells. They're primary cells involved in nonspecific and specific immune system responses. The normal value for these is 4,500 to 10,000. They develop from stem cells into three major groups, which are below. So starting with granulocytes, these are involved in the inflammatory response. They make up the greatest number of normal blood leukocytes, so 60 to 80% of those, and are divided into neutrophils, eosinophils, and basophils. Monocytes are involved in inflammatory response as well. They're the largest type of leukocyte and mature into macrophages. And then lymphocytes, which are involved in specific immune response. They make up about 20 to 40% of circulating leukocytes. They're divided into B cells, T cells, and natural killer cells. T lymphocytes or T cells provide cell-mediated immunity, and they mature in the thymus gland, whereas B lymphocytes are responsible for humoral immunity and mature in bone marrow. We'll discuss humoral and cell-mediated immunity later in the PowerPoint. And then natural killer cells, which kill virus-infected or tumor cells.
This slide is just
so this is just kind of a nice chart that tells you the different types of cells of the immune system. So I'll let you look at that.
Stem cell, and then the various subdivisions of cells within the immune system. This slide gives
and this is also a good one that shows you the different
and as you can see on the left-hand side of the slide,
organ and body systems that have to do with the immune system.
You know, the parts of the body that also help with immunity. You know, the lymph nodes, tonsils, the thymus, the spleen, which sometimes we don't really think about that, the bone marrow, the lymph vessels, and that funny little organ we call the appendix. On the other side, we talk about some of the pathogens that we do have passive barriers that the skin uses to, to keep out the germs, the bad germs. That would be the skin, the mucous membranes, and the stomach acid. We have that innate immune system, which is the complement response system, the phagocytes, the granulocytes. And then finally, we have the adaptive immune system, which is the lymphocytes, the B cells, and the T cells.
So humoral immunity, this is mentioned in your book in Burke on page 238. So B cell lymphocytes are responsible for antibody mediated or humoral immunity. When antigen enters the body, the T cells activate the B cells. They differentiate into plasma cells and memory cells. Plasma cells are what provide the actual antibodies or immunoglobulins that are released into the bloodstream. So these immunoglobulins have 5 classes. They are listed in your book as well as on the next slide. So they are IgG, IgA, IgM, IgD, and IgE. Memory cells are the cells that remember a prior exposure to a particular antigen and then rapidly inactivate the antigen. So say you've had an illness and you've developed antibodies, these memory cells are the ones the next time you have the illness that start to fight off that illness and try to destroy it for you.
This slide talks
so like
I
said, this is in your book in Burke on page 240. I just took a picture and entered it here. So this just tells you about the different immunoglobulins and what they do. You don't need to focus a ton on this, but you should know certain ones that are mentioned throughout the unit.
After an immunization. The IgA is in external secretions such as saliva and mother's milk. The IgE is the allergic symptoms for an immediate hypersensitivity reaction. IgM is the antigen receptors on a lymphocyte surface prior to immunization. And then the IgD, the antigen receptors on the lymphocyte surface again prior to immunization. And they have other functions that are unknown. So those are the immunoglobulins.
And then cell-mediated immunity. So this is when T cells are the foundation for cell-mediated immunity. So there's 3 types of T cells. There's helper T cells, which are CD4 plus cells. These are responsible for turning on your immune system and recognizing antigens such as a virus or transplanted tissue. Suppressor T cells, these are CD8 cells. They limit the immune response so that the body doesn't destroy itself. So basically, suppressor T cells, what you should know is that they're important in preventing autoimmune disorders. And then cytotoxic T cells can destroy cancer cells, cells of transplanted organs, and grafted tissues. So these are vital in the control of viral and bacterial infection. However, you can see why you would need to be on anti-rejection medications, say, for a transplant, because these are going to be the medications that will, or the type of cells that would destroy these. It does not involve production of antibodies at all, so that's the big difference between cell-mediated and humoral immunity. So different types of immunity, these are listed in Burke as well on page 241. So innate immunity is a person's resistance to foreign substances that occurs because of gender, race, hereditary, age, or health status, does not produce an immune response. So basically individuals are just naturally protected because of their physical and chemical barriers. So this is just our natural immunity to things from outside our body, okay? And then moving on to active immunity, there's two different types. There can be naturally acquired or artificially acquired. So the best way I know this is naturally acquired active immunity is when you actually have the disease yourself and you develop antibodies to that disease, okay? And then artificially acquired is when you have an immunization. So say you have an immunization for influenza. Now you've had an artificially acquired active immunity to influenza, okay? And then looking at the other side, there's passive immunity, and there's also naturally or artificially acquired. Naturally acquired passive immunity is from neonates through breast milk and placenta. So the biggest thing I think of here, mothers will get a whooping cough vaccine before delivery. The neonates will then get antibodies through mom's breast milk to that disease for whooping cough. So that's why we encourage that in pregnancy, to help avoid the baby getting whooping cough. Obviously, any other antibodies mom has, this is going to also come through the breast milk to baby. That's why they say breast milk babies are more likely to have less illness and that kind of thing after delivery. So that's the biggest thing with naturally acquired. Just think of mother to baby. And then artificially acquired passive immunity is when you get an injection with ready-made antibodies. So this is when someone would maybe get an injection of immunoglobulins. One good example of this is when patients are exposed to hepatitis A. They will get immunoglobulins afterwards to acquire immunity against this. Just one thing with this, just know that they're not long lasting, whereas the others are going to last years to a lifetime. So any of the active immunity could last a year to years to lifetime. This is just a good example that kind of shows you the differences between the two. It's another thing to help you remember this. I really would encourage you guys to know the differences between all of these, not only for exam purposes, but also for your boards. I know that these are questions that get brought up a lot. So looking at an NCLEX review question, so the nurse is assisting in administering immunizations at a healthcare clinic. The nurse understands that immunization provides which? And the answer would be number 4, artificially acquired active immunity from disease. Okay, so looking at this, if we look at number 1, artificial acquired passive immunity, this would be through injection of serum antibodies from another person or animal, aka immunoglobulins, so that's why this would not be an immunization. 2, this is just our body's natural immunity. And 3, this would be more of a neonate through a mother's breast milk and placenta. A couple diagnostics that you'll need to know for immune system. So serum immunoglobulins, these are measuring the level of the IgG, IgA, IgM, IgD, and IgE. IgG will be increased with acute infections, and IgG, IgA, and IgM will be decreased with cancer. Antibody titer testing, so this is one that you guys will see very often and have probably had yourselves. So this is determining whether antibodies were developed in response to an infection or immunization. So one of the most common ones you'll think of is a hepatitis B titer. After you've had your hepatitis B immunizations, they may do a titer to make sure that you are immune to hepatitis B. And then another one that you guys are commonly known with is skin testing. So injecting of a known antigen, and assessing response. So one example of this is a TB skin test. Moving on to hypersensitivity reactions. So hypersensitivity is an altered immune response where the body overreacts to an antigen, resulting in harm to the patient, okay? So first looking at type 1, which is immediate hypersensitivity. So an allergen binds to IgE antibodies, and histamine is released. So some causes of this would be things like pollen, foods, insect bites, animal dander, and drugs. And then some examples of this would be an allergic asthma, hay fever, insect sting reactions, food allergies, or anaphylaxis. Okay. Then looking at type 2 cytotoxic hypersensitivity, so this is IgG or IgM antibodies bind with an antigen such as AB or Rh, and then triggers autoimmune destruction and systemic reaction. So type 2, one of the causes is incompatible blood, and then examples are going to be from blood transfusion reactions or hemolytic disease of the newborn. So what I think of here is those moms that are Rh incompatible with their babies. The babies can have the hemolytic disease due to cytotoxic hypersensitivity in their bodies, okay? And then type 3, immune hypersensitivity. So IgG or IgM antibody antigen complexes form in circulation and then begin the inflammatory process. Some causes of this can be extracellular bacteria, viruses, or molds. So type 3 examples are serum sickness or aka illness in the blood, systemic lupus, or rheumatoid arthritis. And then lastly, type 4 is delayed hypersensitivity. So T lymphocytes interact with the antigen and activate the inflammatory response. This can be delayed for 24 to 72 hours after exposure. So some types of this, you can have chemicals or causes, I apologize, chemicals or plants, skin tests with fungi or mycobacteria, and foreign tissues. So one thing I think of that, a skin test with mycobacteria, so a TB test is going to be a delayed hypersensitivity reaction, okay? Other examples are contact dermatitis or graft or tissue transplant reactions. So good one to think of with delayed hypersensitivity is you get a TB test, and that's why we have it read 72 hours later, so that we are making sure you don't have a delayed response to that. Moving on to latex allergy, there is a list of latex products in your book, Burke, in box 11, on page 245. So definition is just reaction to latex proteins entering the body through the skin mucous membranes, IV tubes, lines, or drains, or inhalation. It's a type 4 response that results from processing chemicals, so it can develop 24 to 48 hours later. However, it can also progress to a type 1 response within minutes of exposure. Symptoms of type 1 response can range from hives and itching to wheezing, dyspnea, laryngospasm, and cardiac arrest. So basically, if you think of anaphylaxis as type 1, latex allergies, people can have reactions delayed where they just have like a rash or hives later, or they can be very, very serious and have these big reactions. Prevention is key with this, so knowing that they have a latex allergy and avoiding any latex products near the patient. Some patients will have cross sensitivity to certain foods if they have a latex allergy as well. So avocados, bananas, kiwi, and pineapple. Definitely true. So my mother has a latex allergy and she is also allergic to bananas. So just keep that in mind that you'll want to know any kind of dietary allergies as well for these patients. And sometimes they may not even know if they're not someone that eats this very often. So obviously if they've said they have a latex allergy, maybe just check with them on these things before we are just giving them a regular diet and giving them that kind of food, okay? Hypersensitivity to medication responses. So there's three different types of responses you can have. You can have a local reaction, a systemic reaction, and an anaphylactic reaction. You guys should pretty much know what these three are, but we'll still go over them just so you know. So obviously, if you think of a local reaction, it's just going to be something at the site. So you're going to have redness, swelling, inflammation, that kind of thing at a local site. Whereas systemic is going to be where it's more systemic in your body. You're going to have fever, chills, redness, swelling, that kind of thing kind of spreads from that local site and continues throughout the body. And then lastly, anaphylactic reaction. This is when they're going to have an acute allergic reaction. It can be within minutes of exposure. They'll have itchy palms, swollen eyelids, hives, and then progress to stridor, tachycardia, laryngospasm, and shock, and again, possibly cardiac arrest. So this is just a good picture of a local reaction. They probably had an injection right here and they'll have redness and that kind of thing. Biggest thing I think of with this is when you give an injection of an immunization, like most people have the sore arm or the redness and swelling around the injection site. That's completely normal, but it's just a local reaction. Systemic reaction, so this guy is going to be more ill. He's going to have fever, chills, sweating, just not going to overall feel good from whatever is going on. And then lastly, anaphylactic reaction. So this little guy obviously had a anaphylactic reaction, has really bad swelling in his lips. They must not be worried about airway if they're already in a hospital and taking care of him, but he obviously had a really quick reaction to something. Then as far as hypersensitivity detection, there's a couple different tests you can do. In Burke on page 245, we'll talk about these. So RAS test, or radioallergosorbent test. This measures the amount of IgE to specific allergens. It's very expensive and time consuming. However, with this test, there is no risk for an anaphylactic reaction to something you don't know you're anaphylactic to. So this is something that someone with like very serious allergies may consider doing to know what they're allergic to. But again, just very expensive for the patient. A skin test is to identify specific allergens that a person might be sensitive to. It's based on the patient's history, so test solutions are injected intradermally or by a prick or patch on the back or the arms. And we'll talk about those two as well. So a prick test, this may be done first just to avoid a systemic reaction. So basically, a drop of an allergenic solution is placed on the skin, and then through the drop, the skin is punctured. And basically, if they have a wheal and redness within 15 to 20 minutes, then it's positive. And then as they go farther, they'll do an intradermal test. So this is actually a small amount of the allergen is injected. If several are being treated, they'll space them about a quarter to a half inch apart just so that they know what each one is. A plain dilutant will also be injected about opposite of the test site, just as a control measure to show what normal reaction is. And then a positive test will be, again, if there's a wheal and redness within 10 to 15 minutes. Okay. Actually, excuse me, about 15 to 20 minutes for the intradermal test as well. And then lastly, a patch test. This is when a 1-inch patch of impregnated with the allergen is applied to the skin. And this will actually stay on the skin for 48 hours. And then positive responses range from mild redness to severe redness, papules, or vesicles. But they'll basically have these little patches that are taped onto them, and they'll keep them on for 2 days to see what their reaction is. And we do have a couple pictures as well. So this one here, you can see a couple different responses. So this was probably more of a puncture intradermal test on a little kid's back. So you can see where those big wheals are. Obviously, those are things that she's going to have bigger reactions to, whereas the small redness is just kind of a local reaction, no big deal. Pharmacology as far as hypersensitivity reactions go. So obviously the number one thing we're going to think of here is epi. Epinephrine is going to be given during acute anaphylactic reaction. It is also known as an EpiPen. A lot of people that have allergies will have these on them, but they are really expensive. Just keep in mind this kind of reaction systemically that the patient's going to have when you're giving epi. Obviously their heart is going to start racing and that kind of thing. But just keep that in mind. And then antihistamines are a major class of drugs used for treating symptoms of hypersensitivity reactions. A couple things I think of here are things like Benadryl. Those are going to be used for these kind of symptoms. Nasal decongestants, one of them is Afrin. These can be used to relieve allergy symptoms, as well as oral decongestants. Sudafed is the most common one I can think of then. Glucocorticoids or corticosteroids, these are used in both systemic and topical forms for different types of hypersensitivity reactions. They have anti-inflammatory effects, so topical forms or inhalers can be used for longer times with fewer side effects. However, if we need to do like a topical steroid, they can do that as well. And then desensitization, this is a form of an immunotherapy. And what this does is they inject small doses of an allergen weekly, and over time antibodies develop to block that allergic IgE response. So this is a way that we can help people with allergies to kind of desensitize them to those allergies. So just keep that in mind. It's kind of a different therapy that is used. Most people with allergies probably are more likely to do antihistamines and decongestants, but it is an option if they decide they want to go further. An NCLEX question here. A client is brought to the ER and is experiencing an anaphylactic reaction from eating shellfish. The nurse should implement which immediate action? So the answer here is going to be number 1, maintaining a patent airway. Airway is always going to be one of our first concerns when it comes to a patient that has an anaphylactic reaction. We may do all of these. However, number 1 is going to be the first thing that they should do immediately. Moving on, autoimmune disorders. So these are immune system mistakes the self for non-self, and body reacts against its own cells. So the self-attack results in tissue damage and chronic inflammation. It can affect any tissue, cell group, or organ in the body. The onset is often associated with a severe physical or psychological stressor, and manifestations vary according to tissue or organs affected. Most often signs of inflammatory process, so pain, fatigue, fever, and then treatment is going to be based on relief of symptoms for these people. A couple of different types of autoimmune disorders that you'll be able to look up on your own. Some of them we've talked about already, and then some of them are in this unit. But first one is idiopathic thrombocytopenia purpura, thyrotoxicosis or Graves' disease, type 1 diabetes, Addison's disease, multiple sclerosis, myasthenia gravis, pernicious anemia, ulcerative colitis, rheumatoid arthritis, and systemic lupus erythematosus. Okay, moving on to HIV and AIDS. So talking about pathophysiology to start with. So HIV is a retrovirus, meaning it produces in a backwards manner. So rather than using DNA to end up copying the cells, they'll use the RNA to make DNA copies. The virus attaches to CD4 plus and T4 helper lymphocytes. Once inside that CD4 cell, the virus sheds its protein coat, releasing an enzyme called reverse transcriptase to convert RNA to DNA. And then the viral DNA inserts itself into host cell DNA and duplicates through normal cell division. So basically, it gets inside the CD4 cell, it converts RNA to DNA, injects itself into the host DNA, and then that DNA just continually replicates just like it normally does in the body. Okay. The loss of the helper T cells leads to the immunodeficiency seen with HIV. Eventually, it overwhelms the body's immune system and will eventually obviously progress to AIDS. Diagnosis of HIV is going to be based on patient history, risk factors, physical exam, lab studies, and then manifestations. So speaking of manifestations, they range from no symptoms to severe immunodeficiency with multiple opportunistic infections and cancers in the late stages. So after primary infection, the patients enter a long-lasting asymptomatic period, which can be about 10 years long. Obviously, transmission is still possible during this time. They are still infected. However, they just are asymptomatic. And then acute infection is characterized by persistent generalized lymphadenopathy lasting 3 or more months. It's unclear what exactly causes a patient to progress from HIV to AIDS. However, once it does progress to AIDS, it affects almost all of the organ systems. And then patients with AIDS have a poor prognosis. However, newer treatments and medications are enabling them to live longer. Once they progress to AIDS, the risk of those multiple opportunistic infections and cancers obviously increases greatly. So these are just a good little example of signs and symptoms they can have with HIV infection. I'll let you guys review those on your own. And this is also a nice little chart that talks about the stages of HIV. So again, there's that acute infection and there's that latency phase where it's there, but it's just not symptomatic, and then eventually they'll progress on to AIDS. So moving on, we're going to talk about the opportunistic infection. So really good in your book on Burke in page 254, it'll talk about this. So opportunistic infections are most common manifestation of AIDS, and they usually develop simultaneously. So the risk for opportunistic infections is predictable by looking at the CD4 T cell count. So a normal CD4 count is 800 to 1200. When it's less than 500, they usually have manifestations of immunodeficiency. And then when it's less than 200 is when you're going to see these opportunistic infections more likely. Okay, so a couple ones that affect the respiratory system. PCP pneumonia is the biggest one I think of. In your book, it is actually a PJP pneumonia. But this is one of the most common opportunistic infections that people with AIDS will have. It settles in the lungs and then damages the alveoli of the lungs. So your patient may experience fever, non-productive cough, shortness of breath, dyspnea, tachypnea, crackles, decreased breath sounds, and cyanosis. Diagnosis for this will be made by chest x-ray or bronchoscopy. Another common infection is going to be tuberculosis for these patients. So the co-infection significantly decreases the patient's survival time. So if they do likely get tuberculosis, they're not going to survive for very long, but just know that it is a common opportunistic infection for them. Obviously, patients with these are going to have persistent cough, night sweats, fever, fatigue, and weight loss. Moving on for GI, candidiasis or thrush. This is going to be a fungal infection that's characterized by white patches in the mouth, esophagus, and stomach. This is common for an opportunistic infection for HIV and AIDS. Cryptosporidium, so this is a type of parasitic infection that can affect the GI system. It causes watery, non-bloody diarrhea and often leads to dehydration, electrolyte imbalances, and malnutrition. And then wasting syndrome. This occurs in most patients in the late stages of AIDS. It's an unplanned weight loss of 10% along with chronic diarrhea or an unexplained fever. This is what makes patients with AIDS appear really emaciated. They just look like they're completely wasting away. And then a couple other ones that affect the neurosystem, so toxoplasmosis or cryptococcus. These are parasitic infections as well. They both affect the brain. So toxoplasmosis can cause encephalitis. And then crypto is settles in the lungs, but then can travel to the brain or meninges. So fever for both of these, headache, stiff neck, altered mental status, and seizures. So basically any kind of neuro symptoms you can think of will affect these. And then a couple other systems that are affected by opportunistic infections. So these patients are at higher risk of herpes simplex 1 and 2. Cytomegalovirus or CMV, this is a part of the herpes virus family that can affect the retina, GI tract, or lungs. So it's a primary cause of blindness in patients with AIDS. And then human papillomavirus and pelvic inflammatory disease, they both have high incidence in women with AIDS. Women with AIDS are at increased risk of cervical cancer, and most that are diagnosed actually die from cervical cancer rather than from the AIDS itself. Just to go back for a second, so lymphomas, just keep in mind that while this is a secondary cancer that they develop from AIDS, people with lymphomas don't just have AIDS. That's not, it's two different things, but it's just a common cancer that affects these people because of the infection, okay? Diagnostics, so there's ELISA, Western blot assay, HIV viral load test, CD4 count, CBC, TB test, cultures, etc. A lot of these are mentioned in Burke on page 256. So ELISA is the most commonly used screening test to determine the presence of HIV antibodies. If the test is positive, they would do a second test to confirm this. If the second test is positive, then they would move on to doing a Western blot assay, okay? One thing I think of with this is obviously it's probably high cost to do a Western blot, whereas they could do this enzyme-linked immunosorbent assay maybe for cheap, and if they don't have a positive response, then they don't need to move on to a more expensive test. So Western blot, this is going to be a reliable test used to actually confirm that the patient, again, is HIV positive. HIV viral load test, so this measures the amount of HIV viral activity. It monitors the disease progression. Basically, if they have levels greater than 5,000 to 10,000, it indicates that they need treatment. Then moving on, CD4 count. So this is to confirm progression from HIV to AIDS. We talked about it a little bit on another slide, but I'll go over it again. So normal is 800 to 1,200 for CD4 count. When they have less than 200, that's when it's diagnostic of AIDS. And then CD4 counts are recommended every 3 to 6 months for anyone with HIV to monitor for this progression. CBC is going to detect things like anemia, leukopenia, and thrombocytopenia. You should know that, obviously, anyways, but this is why we're doing it on these patients. TB tests to identify any secondary TB infections. And then cultures of urine, blood, stool, spinal fluid, and sputum could be used to identify any of those secondary disorders that could occur. So the PCP pneumonia, toxoplasmosis, crypto, those kind of things. And then lastly, a CT or MRI could identify lymphomas or any other opportunistic infections. Medications for AIDS, so antiretroviral medications. These have three main functions. They reduce the patient's viral load, they maintain their CD4 counts above 500, and treat opportunistic infections and malignancies. So there's a couple different kinds. The NRTIs, These inhibit action of reverse transcriptase to try to prevent HIV reproduction. So again, when we talked in the beginning about reverse transcriptase, that's kind of what starts the whole process of the DNA replicating the HIV virus. So this helps to prevent that. And NRTIs, these block the HIV reproduction altogether. Protease inhibitors, these can block production of HIV protease enzyme, which is needed to make the mature virons. And then in your book, it talks about HAART, which is a high antiretroviral medication therapy. This is a combination of 3 to 4 medications. So another NCLEX review question. So a client with AIDS is diagnosed with cutaneous Kaposi sarcoma. Based on the diagnosis, the nurse understands that this has been confirmed by which? The answer is 3, a punch biopsy of the cutaneous lesions. Again, we talked about this. The biopsy is the only way to confirm diagnosis. And that's all for immunity and HIV/AIDS. If you guys have any questions, feel free to email me or Ashley over fall break and we can answer those for you. Good luck to you guys and enjoy your break, and then we'll see you back for your first quiz.